Hi everyone. If you've covered the first one that we went through, we'll now be covering the second one, which is actually the rhythm. So, for those of you who have been on the group for a little while, you'll notice that a lot of the ECGs that we post don't actually cover a lot of ischemia. Um, you'll notice that we tend to cover a lot more rhythm abnormalities and rate abnormalities. And the reason for that is in medical school, there is this perception that's created that it's either an infarct, in other words, it's a heart attack, or it's not a heart attack, or it is a myocardial ischemia, or it's a STEMI or an NSTEMI. But in truth and in reality, while we are on the floor, the majority of the problems that we see, I would say from all of your abnormal ECGs, only about 15 to 20% of them are actually ischemic. The other 85% comprise rhythm and rate abnormalities. So today we're going to cover the second one, which is the rhythm. So we're going to start talking about the rhythm strip, that little thing that comes at the bottom of the ECG. All right. So the first thing that we need to know is what's a normal rhythm. What would we consider normal? And once you know what's normal, then it's very easy to figure out what's abnormal. Okay, so what we're going to do in this session, we're going to concentrate on looking at a normal rhythm. We're going to break it down. We'll then look at some of the more common abnormal rhythms, although we won't be worrying too much about diagnosis, but rather just about figuring out the abnormality. And then hopefully after that, you'll be a bit more comfortable in assessing the rhythm strip. Okay, all right, so let's go through it. Let's just have a look at this. We have what looks like a normal looking ECG. All right. So we have, and if you just look at it just like that, it just looks normal. But the question is, why is it looking normal? What is it? What is it about this that makes it normal? So there's actually 5 criteria that we use, and that's what we're going to talk about now, right? So what we have here is what we call a normal sinus rhythm. So yeah, as I say, it's referred to as a sinus rhythm. So confirm this thing, you must have 5 criteria. This was written a long time ago. So we're going to have 4 and 4.1, all right? 1 and 1.1. So the first thing is that you need to have normal P waves. So remember, P waves talk about your atrium. That's when your atrium contracts, you get a P wave. They mustn't be too wide. They mustn't be biphasic or bifid and things like that. Criteria 1.1, which isn't in here and should be in here, is your PR interval. So your PR interval means the time it takes from your atrium to contract to your ventricle to contract. So this should be a standard time. In other words, it mustn't take too long for your atrium to contract, and then too much time passes before your ventricle contracts. And the converse is true. You can't have your atrium contracting, and in a very short while your ventricle contracts. It means there's something wrong there as well. And then you should have narrow QRS complexes, all right? Once you have wide complexes, it implies that actually your SA node is not necessarily involved once you start getting a wide complex. Not necessarily that it's ventricular, but at least that it's not the uh, SA node that's involved. Does a QRS follow each P? In other words, does the atrium beat and then the ventricle beat? So is the ventricular beat following the atrial beat? That's basically what we're saying over here. And then do these batches of P QRS wave complexes occur regularly? So essentially what we're learning to do is lubbed up. All of us remember lubbed up from the time when we were kids. Our heart makes a sound lubbed up. You can make lub the equivalent of your atrial activity and dub the equivalent of your ventricular activity. So today what we're learning is lubbed up. Is this heart doing lubbed up or is this heart doing something else? And these are the 5 criteria that you need to know in order to say that lubbed up is occurring. All right. So atrium must contract 1.1, which I haven't put over here. Sorry about that. So the atrium must contract. The time from the atrium to the ventricle contracting should be normal. The ventricle should contract in a narrow fashion, so the electricity should pass through it quickly. The ventricle must contract every time that the atrium contracts, and it must occur regularly. So, in other words, we mustn't have lubbed up, right? So, in other words, we mustn't have an atrium that takes too long. You mustn't have lubbed up, and you mustn't have lubbed up. 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 You must So not too much of a gap, not too little of a gap. You mustn't have lub dub. You mustn't have a dub that's too long. I know I'm making it sound very silly, but it's just to make the point. You must have lub dub, lub dub, lub dub. You can't have lub dub dub or lub dub. All right, number three. And then you need to have lub dub, lub dub, lub dub. You can't have lub dub, 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 lub dub. So I know it sounds very silly, and if you're having a good laugh, I hope that you will keep it in your head so that you'll understand what we're trying to figure out. We're basically trying to make sure that lub dub is happening and it's happening regularly. Okay, so let's look at that rhythm strip again. So let's look at number one, our P waves. So there's our P wave over there, all right? It's a nice normal looking P wave. Now the reason your P wave is smaller is because your atrium is smaller, so it doesn't release as much electricity, all right? So you see a normal looking P wave. It's not too big, it's not too small, it's not too high, it's not too low, it's not biphasic, it's not ridged, there's nothing, it's just normal. 1.1, the PR interval. So in other words, from that P to that R should be a constant. Now what we say is between 2 to 4 of these small blocks. So let's count this particular one. You've got 1, 2, 3, 4 on the head. So it's within normal. Once you start going above 4, then it's no longer normal. And once you go below 2, so in other words, this is too close to that, or this is too far away from it, that's abnormal. Then you need to have narrow QRS complexes, what we're talking about, your narrow complexes. And we'll talk about them in a little while. All right, so we've got that there. Does a QRS follow after every P? So in other words, do you have a P wave and a QRS? P, QRS, P, QRS, and we see that we do. And are the complexes regular? So in other words, are they occurring at a regular interval? Now, in saying that, we all have something that is called sinus arrhythmia. What that means is, and you can check it yourself, breathe in, your heart beats a little bit faster, breathe out, your heart beats a little bit slower. That's called sinus arrhythmia. It's quite normal. You are supposed to have that. So you'll never have them exactly, but the time difference is so negligible that they should actually be quite, you know, regular when you look at them. All right. So that's why we call that a sinus rhythm. So what we're going to do now, and you can try this, what you can do is before I give you the answer, pause the video, look through the whole thing and see if you got it right, whether you had a normal or an abnormal diagnosis. Okay, so don't worry about the diagnosis. Actually, you just need to say, is this normal or is it abnormal? We'll learn about diagnosis as we go on. Okay, let's start. So let's look for all 5 criteria. I need to change this. I'm so sorry. All right. So what you can do now is if you want to try it yourself, pause the video now, try it out, and then you can listen to what I have to say. Okay, so let's look at our criteria. We've got P waves, all right? We can see our P waves, they're quite regular. They're not too high, they're not too wide, they're not too biphasic, nothing like that. So our P waves are normal. So our atrium is functioning normally. Our PR interval is about 1, 2, 3, 3.5. So that's within normal. Our QRS complexes are narrow. We can see that they are narrow. A QRS is following every P, so that's good. And we can see that the batches are regular. So what we have here is a normal sinus rhythm. Okay, so that's how it's supposed to be. So if you got that right, great. Let's move on to the next one. All right, so it's a normal strip. There's nothing wrong with that. Okay, let's look at this one. And again, if you want to challenge yourself, pause the video now. I'll give you a minute and then I'll start talking in a little while. Okay, so let's look at the P waves here. So just the P waves themselves. So we can see that the P wave, quite normal, maybe a little bit peaked, but it's not so abnormal that we can say that it's abnormal morphologically. Okay, it's actually quite within normal. So we just looked at that criteria. All right, let's look at the PR interval. So here we have a PR interval. Here we can see we don't have a PR interval. We have a PR interval, no PR, no PR, no PR, and then we have a PR interval. But if we just look at the PR interval itself, it's 1, 2, 2.5. So where it occurs, it's normal, all right? Now, I mean, it doesn't take a genius to tell you that this is abnormal, but let's go through all the criteria. So we have narrow QRS complexes, all right? Are our QRSs following every P? No. We can see they are P waves, but there are sometimes no QRS complexes. So there you have a P wave, no QRS, P, no QRS, P, no QRS. And then you come again and you have a P QRS, P, no QRS. So that's where our first abnormality comes about, okay? And our grouping is regular. Of course, they can't be regular because you've got QRS complexes that are missing, okay? The diagnosis is not important. Just as long as you said abnormal and you understood why, you've done very well there, okay? So there we go. It's an abnormal one. The P waves are normal. PR interval where it occurs is normal. Complexes are narrow, but there isn't a QRS after each P wave, and the groups are irregular, very irregular actually. Okay, let's go to the next one. So again, if you want to try it out yourself, I'm going to stop talking now for a minute. Okay, so let's have a look and see. So let's look for our P waves. So what can we see? Number one, there's no P waves. Nothing. There's not a single P wave over here. So we immediately know something is wrong. All right. Our atrium is not functioning. So we can't talk about a PR interval because we don't have a P wave. We can't talk about a QRS following every P, but what can we talk about? We can talk about the QRS complexes themselves. They are narrow. All right. And are they regular? Yes, they're actually quite regular. So if you said it was abnormal, very good. If you said it was normal, not a problem. We all live and learn. All right. So there we go. We have narrow complexes, groupings are regular, but the most important thing, there are absolutely no P waves. Okay. So even though it looks normal, something's happened. Why isn't our atrium functioning? Now, because I'm speaking to most of you guys who are students who've asked for this now, or maybe even new interns, when you see this and your patient is having symptoms, that means that even if you don't know the diagnosis, you know that something is wrong, which is the most important thing at your level. If you see something is wrong, don't be quiet. Take it up, go and ask somebody what's going on over here. Why is it that my patient has an abnormal rhythm strip? And let them make a decision as to what to do, which is all that's required. I mean, this is a very technical ECG rhythm strip actually. And if you don't know the diagnosis, that nobody will fight with you about it, but at least you knew it was abnormal, and that's the most important thing. Let's go to another one. All right. So again, if you want to challenge yourself, I'm going to keep quiet for a little while. All right. So let's look at our P waves. So where our P waves are occurring, we can see that they actually look quite normal. There's no problem with the P waves. They actually look okay. And in fact, the P waves are actually occurring quite regularly. They're happening at a regular interval. Okay. The PR interval, we can't really talk about it because it's all over the place. There's PRs short, long, extremely long, no QRSs, all of that. So we forget about the PR interval for now. Our QRS complexes are wide. Okay, quite wide actually. And our QRS, we don't have a QRS following every P. In fact, quite a few are missing. Okay, so what we have here is a wide QRS complex. So that means that we have an atrium that's functioning. And remember what I told you, if you have a wide QRS complex, it means that the ventricle is not getting its input from the SA node. So that means the ventricle is either producing it from itself or it's getting it from somewhere else. All right. So let's take a minute and look at this. So we have an atrium that's working. We can see that it's working, and we can see that it's working regularly. And we have a ventricle that's working. It's also working regularly, but very slowly. And it's working independently of the atrium. So you've got a ventricle that's working on its own, and you've got an atrium that's working on its own. And this is a type of a heart block. The reason why we say it's a heart block, because there's a blockage between the atrium and the ventricle. Now, there's 4 types, but we're not going to get into that right now. The most important thing I want you to think about, if there's no association, as you can see here, there's nothing to combine a ventricle with an atrium. The atrium is functioning completely independently, and the ventricle is functioning completely independently. Do you think this is a partial or a complete heart block? Well, if you answered complete heart block, you were absolutely right. If you answered partial, don't stress. Remember, the reason why we say it's a complete heart block is because there's absolutely no connection between these atriums and these ventricles. Okay, so a lot of people ask, well, why does this ventricle now give off this wide QRS complex? And I always give the example, the pathophysiology of it is quite complex. And if you have time and you're one of those people who likes to know every little detail, by all means, go and read it. You as a student come to work at Madadeni Hospital. You get an ECG and you are the AV node. All right. So you've got this work to do, but you're not sure of how to get it done. You ask Dr. Mohammed, who is the SA node. I come as the SA node, come to you as the AV node, and I tell you do A, B, C, D, and E. You immediately know what to do and you do it quickly. Now, that's a simplistic way of putting what happens between the SA node and the AV node, but it is essentially what happens. The SA node keeps on telling the AV node what to do, so the AV node knows exactly what to do. Once there's a problem between the SA node, the atrium, and the ventricle kind of keeps on looking up. If you can imagine it looking up from where it sits, it's looking for the SA node, but it can't see the SA node. And it's kind of like you now being in that same situation. You've got an ECG in front of you at Madadeni Hospital, but now there's no Dr. Mohammed. It's just going to take you a little bit longer to come to the same conclusion. I know it sounds simplistic. It may even sound like I'm making it up, but that's basically what happens. The AV node kind of looks for an impulse, it doesn't get it, and then it has to pass this impulse along on its own. The pacemaker cells that are involved, the way that they discharge, the cell membranes, there's a whole lot of things that goes into it as to why it becomes as big as it does. But that's why you start getting wide QRS complexes. Okay. So if you've never seen a complete heart block or third degree heart block, this is a third degree heart block. And now you know why they call it third degree. Okay. Very good. Let's try another one. So this is just going through what we were talking about. Okay. So we're not going to dwell on that for too long. So let's take a look at this one. So again, if you want to challenge yourself, write down all your criteria and I'll wait for a minute. You can pause. Okay, so let's look for our P waves here. So the first thing that you'll notice is we can't really make out any P waves per se. So there's just this line. It's just sort of a jagged line. There's nothing much going on. So we can't talk about P waves. So we immediately know there's something wrong. So we can't talk about a PR interval. We can't talk about a QRS following after every P. But what can we talk about? We have narrow QRS complexes. And are they regular? No. In fact, they're absolutely irregular, completely irregular. There's absolutely nothing binding them together. The rates completely differ from one beat to the next. Okay. So if you guessed it was abnormal, then you did very well. And we'll talk about these ones in the next lecture. Don't worry about that. Like I say, the most important thing is it normal or is it abnormal? But it is. All right. So no discernible P waves. The groupings are irregular. There's no association between P's and QRS, but complexes are narrow. Okay, so let's try another one. So let's look at our P waves. Here we have a P wave. Here we have a P wave, a P wave. So if we look at the actual P wave, the P wave looks quite normal. It's not abnormal in terms of its sorry, in terms of its morphology. And sorry, I forgot to actually pause. But anyway, you can pause and still challenge yourself if you want. Okay, and let's talk about the PR interval. So let's look at this. We've got 1, 2, 3, 4 blocks. So that one's normal. Then on the next beat, we've got 1, 2, 3, 4, 5, 6. Okay, that's abnormal. Then on the third one, 1, 2, 3, plus another 5. That's 8, 9. So we've got this elongating QRS complex. And then we come to a P and we've got a dropped, and there's no QRS complex here. And we see that pattern repeating. So we already know there's a problem with our PR interval. It's elongating. So already we know this is abnormal. Let's go through the rest of our criteria. Our QRS complex is narrow or wide. They are quite narrow. Does a QRS follow every P? No, it doesn't. You can see there are areas where there's no QRS complex. So it's abnormal, and so it must be irregular. By definition, it can never be regular because there are missing beats. Okay. So if you answered abnormal, very good. Okay. So this is just going through what we're talking about. All right. Complexes are narrow, P waves are normal. Not every P wave has a QRS following it. Groupings are irregular. And then you have a widening PR interval. Okay. So if you were to become a physician or to become a cardiologist, there's two huge volumes of books, literally huge. I'm talking about like 700 or 800 pages each, that talk about rhythm abnormalities. And those rhythm abnormalities essentially are a mix and match of those five criteria that you just learned. So all of these ones that we see more commonly, first degree, second degree heart blocks, atrial flips, AV junctional rhythms, ectopic beats, all these things that you've heard about essentially are just a mix and match of those criteria. Now, this doesn't mean that because you know these five criteria, you don't have to read those books. What it means is that you'd be able to understand what's happening in those books, because that's literally all that they are doing. They are mixing and matching. They are saying for this diagnosis, you've got one or two criteria that are positive, but the other three are negative. In this diagnosis, A and B are negative, but C, D, and E are positive, just as an example. So I hope that you enjoyed that, and I hope that it gave you a bit of incentive to actually go and read a bit about rhythm abnormalities. That's just a bit of a joke just to finish off. And yeah, what we're going to do is then we're going to cover rate as the next one. And I hope you guys enjoyed that. Okay. And if you have any questions, feel free to message me and we can always talk about it. Okay. Thanks. Bye.